In the world of healthcare, we have a lot of acronyms that we use in our everyday language. The topic today, CHEMS, or CHEMS, is no different. It stands for Community Health Emergency Medical Services. The panelists here with us are going to be sharing their experiences of transformation from a traditional EMS model of care to the CHEMS model. They'll give us a brief look at how this will benefit the healthcare systems and other community agencies that they work with, and they'll also give us some insight as to the impact on patients, families, and caregivers under the CHEMS initiative. Do you all find that you have some individuals who utilize the system through the emergency services quite frequently, or how does that come to be?
I mean, one of the things that we use our community paramedic program for is identifying the high utilizers and trying to help them so we can reduce the amount of ER visits and the amount of ambulance demand. So yes, we do depend on that highly.
So you probably get to know them a lot better than some of the infrequent users.
I personally think you'd have to. You know, if someone is accessing or utilizing EMS services in the emergency department over and over and over, what I've found, at least through my work with community paramedicine, these guys I think would probably find something similar, is that people, they don't want to do that. I think inherently they want to be able to manage their own health or navigate that healthcare system. And for a variety of reasons that we learn about through our community paramedic activities, we learn why that is. And that's where you can make that biggest difference.
When we look at our run volume, when we looked at our run volume in Donley, we were like, okay, we had 100 runs. How many of those were emergent, really emergent? Well, we noticed that that number was less than 10%. And we were already doing a community type system, but it was them calling 911. So what this allowed for was a transition now. They're not calling 911, they're being referred and going on to the system of CHEMS, and we're getting them before they do those 911s or going to the ED regularly on a regular basis or the clinic for things that we can handle at their home with the patient care provider and the team of individuals helping them through their time of need.
And then the second thing was to realize what I think is kind of the uniqueness of EMS and EMS professionals. And then taking that uniqueness and seeing how it can be integrated into the larger healthcare system delivery model. So for example, EMS, I think EMS professionals are one of the only professionals in the healthcare continuum that has to communicate with every single person or organization involved. So on the 911 side, we'll have to deal with and communicate with patients in their home, in an emergent setting, bystanders, family members, maybe patients that speak another language. We have to deal with facility, nursing home staff, potentially depending on where the call is. Then we have to subsequently communicate with emergency room physicians or cardiologists or trauma surgeons, and we've had to hone that skill set to be able to communicate what we're finding and what we need to all of those various patients or people. And so just the fact of being able to utilize that skill set, which is unique to EMS, is something that I had to realize. When a clinical plan fails or the structure of a clinical plan starts to degrade, sometimes EMS practitioners are the first ones to be called on the 911 side. And so that uniqueness of having that knowledge and having those interactions with the patient on the 911 side, it gives us a perspective that I think is what is needed in that medical neighborhood concept or that patient-centered medical home concept. And so when you're talking about value, I think that has been maybe that missing piece. And so to have that perspective and that interaction that's unique to us, I think that's where the value comes from with utilizing CHEMS for the primary care provider or the specialty or the other healthcare providers, because it's unique to us.
The lower of rates is I think what's going to help facilitate that mechanism is we're showing ourselves as an EMS system that's, hey, we're here, we're boots on the ground. We probably know these patients better because we've seen their home settings and we can help and be part of those healthcare neighborhood teams that are already assigned to that, and now we're getting to play a part in a role as being part of their healthcare team, and at the home setting on a non-emergent level. And I think what that is as you look at other systems that have been going on so well, and they're growing and growing throughout the country, you're starting to see the benefit to the cost of healthcare in those communities, and how much savings there is because the utilization has gone down and we're getting a better population health. And on top of that, and those individuals that they're looking at in their data sets are like, here's patients that are on the systems, here's patients that are not, and here's how it's benefiting the overall circumference of the system, including the economic factor of what it's costing to give health care in those particular communities.
So I think, can I answer your question? Physicians only see a certain amount of that patient. They see a 20-minute office visit maybe once every 4 months. They don't get to see why that patient keeps coming into the ER or why they're coming into the primary care so much. And so if you have, like, let's take a CHF patient, for example, that comes into the ER because they continue to have exacerbation of their CHF, the physician's like, okay, well, maybe they're not taking their medications or maybe they're not doing it correctly at home. But we find out more of the picture. Maybe they're unable to fill the medication due to finances. Maybe they're not very knowledgeable about low sodium diets. That's something we run into quite frequently. Or, just something as simple as, maybe they have a huge fall risk, and the physician doesn't get those eyes on the whole picture. They only get that 20 minutes or hour that they're in the ER in the physician's office. And I think being able to utilize CHEMS to kind of get a greater idea of how that patient situation at home is will overall improve that patient care's health, or that patient's health, and then which will overall reduce the utilization of that.
It really has changed how I look at patients and their situation as a whole. And I really do believe that people really try the best they can with wherever they are, and with the resources they have and the knowledge that they have. And so now when I'm on a 911 ambulance, I often am spending much longer on the scene than what I used to, sometimes to the dismay of my partners. I am asking additional assessment questions that I never used to. Some things even like, oh, are you a smoker? And if they say yes, I ask if they want information at the emergency department about stopping. I've had more interactions with the emergency department social workers because I have more of a CHEMS concept when I look at patients now, even on the 911 side. And that, I think, as well, is now kind of being passed on to my partners that work with me that maybe aren't community paramedics or involved in CHEMS, but we start to have discussions or they see those interactions, and I think they as well start to look at patients a little bit differently and want to inquire more about why they're in the situation they're in, and maybe is there more we can do for them. And for me, it really has changed how I deliver medicine, and it's on much more of a patient whole or a holistic way of looking at a patient than before.